Good morning to everyone. We are from FOGSI ICOG. I am Dr. Ashok Kumar, Secretary of ICOG. We welcome you for this second Sunday of the month at 11:30 a.m. for this tutorial. Today we are talking about postmenopausal problems. We will be discussing one case on postmenopausal bleeding and another on postmenopausal vasomotor symptoms. We have students from All India Institute of Medical Sciences, Rishikesh, and the coordinator is Dr. Anupma Bahadur, and the case on postmenopausal bleeding will be by students from Al Amin Medical College and Hospital, Vijaypura, and the coordinators are Dr. Vidya Thobi and Dr. Gururaj Deshpande. So this tutorial is always there on second Sunday of the month at 11:30 a.m. in the morning, and it is convenient to all of us on the Sunday holiday. And this is the initiative from FOGSI ICOG under the FOGSI President Dr. Rishikesh Pai and FOGSI Chairman Dr. Lakshmi Shrikande. We have with us Dr. Parag Biniwala as a Vice Chairman of ICOG. And this program is being coordinated along with me with Dr. Hafizur Rahman and Dr. Ashish Mukhopadhyay. Today we have other ICOG past chairperson and ICOG governing council member and fellows also along with us. We have Dr. Hiralal Konar, we have Dr. Shikha Sheikh, Dr. Anupma Bahadur, and Dr. Sarita. Today we have faculty from different places of the country. We have Dr. Vishnu Prasad Das. She is sent a message that she is not well, so she will not be joining. Dr. Vijay Lakshmi is there with us, Dr. Sarita Bhalerao, and Dr. Jyotika Desai. So I am thankful to all of you for sparing your valuable time for this tutorial. I hope this will be very useful and interesting to the practitioner and to the students. And this, I just want to inform you that this program is going on for last 1.5 years, and all the recordings of previous program is on the ICOG website. So I request you to please visit ICOG website also, and you can go through the previous recordings of these programs. We have almost covered all the topics, and we are now just trying to see where all we can pinpoint the problems and we can highlight those. So with these words, I invite Dr. Parag Biniwala, Vice Chairman of ICOG, to say a few words.
Thank you, Dr. Ashok. Good morning, all. I bring greetings from ICOG, the Indian College of OBGYN, which is the academic wing of FOGSI. It's indeed a pleasure to be sitting here listening to all the students and, of course, the examiners in this month's edition of Masterclass, which is a brainchild of our Secretary ICOG, Dr. Ashok Kumar, and Professor Ashish Mukhopadhyay and Dr. Hafizur. This is something which I think all the students are looking forward to, because they get to interact with the examiners, have a mock exam feel, and then that definitely gives them good tips. I welcome all the examiners also. I can see Dr. Jyotika Desai, who I always say is a very kind examiner. So the first batch of students should be very happy that you have an examiner like Dr. Jyotika, and listening to Dr. Jyotika is a learning experience in itself. So over to you, Ashok and Hafizur. My best wishes for the program.
So thank you, sir, Dr. Parag, for your kind words. And we are missing Dr. Rishikesh Pai and Dr. Lakshmi Shrikande. And now I request Dr. Hafizur Rahman to please coordinate and start the program.
Good morning, everyone. Thank you, Ashok sir. Respected ICOG Chairperson Dr. Lakshmi Shrikande, as well as the FOGSI President Dr. Rishikesh Pai. That is, we are doing this program under the guidance, and Dr. Parag Biniwala sir. He has been always there with us, along with Secretary Dr. Ashok sir. So today's program, that is, the idea was that to have coverage on the postmenopausal issues, and the many times the students will become clinicians or later on. So they will be facing. So the idea was to cover on every issues on the postmenopausal, starting from the different vasomotor symptoms as well as the bleeding issues, so that it gives them an idea of, as well as the refreshment of their knowledge for the examination, both for practical as well as for theory purpose. So with this mind in, that is, we categorize these sessions in two different cases. So for the first case, that is students from All India Institute of Medical Science, Rishikesh, who has been guided by Dr. Anupama Bahadur. So they will be presenting a case on vasomotor symptoms, and we would have the examiner from the different parts. So the students are Dr. Dipanshi Garg and Dr. Basundhara Yarkade, and the examiners will be Dr. Ashish Mukhopadhyay and Dr. Jyotika Desai, as well as Dr. Vijaya Lakshmi and Dr. Sarita Balarao. Along with that, sir, I can see Dr. Hiralal Punar sir is also there. He's also an eminent teacher, so we would have to have involvement of other teachers, those for their comments as well as for teaching points to the students. Then for the second case, we have students from Alamin Medical College from Vijaypura. So they will be having presenting a case on postmenopausal bleeding, and they are guided by Dr. Vidya Thovi and Dr. Gururaj Deshpande. So the students are Dr. Vipula S. and Dr. Shabnam. So without having or wasting much time, we would like to have discussion on the case. So for the first case, so I'd invite the students from All India Institute of Medical Science, Rishikesh, that is Dr. Dipanshi and Dr. Basundhara. So please share your screen and start presenting, and after introducing yourself. And I would like to request the faculties to take over and have the students to take from the very basics to the advanced level of discussion on this. So Dr. Dipanshi and Dr. Basundhara.
Yes, sir.
Yes, sir.
Yeah. Mr. Zignesh, Dr. Hiralal Punar wanted to have something. I think you have met everyone.
Can we start, sir?
Host Mr. Jignesh, please unmute Dr. Hiralal. Before we start, I think we can request our past chairman, Dr. Hiralal sir, to say a few words.
Yes, sir. Sir, Hiralal sir, you are unmuted. Yes, sir. Yeah, please.
Thank you, Professor Hafiz, Professor Ashok.
Sir, please, we want to have your
It is not.
Audio is interrupting.
have some your words. Sir, please.
We can hear you, sir. Ashok sir. Hiralal sir.
Thank you very much, Professor Hafiz, Professor Ashok Kumar, Professor Jyotika, for this good session on behalf of the ICOG. Definitely, I believe Professor Hafiz, what he has mentioned, this is a clinical subject, and I believe all of us, be it postgraduate, undergraduates, or practitioner, we need to know the clinical scenario of menopause, the different changes that we were going for, that of the neuroendocrine system. All the body systems are affected, so it is essential that we need to know about these different issues related to menopause, health issues. Obviously, the different abnormalities, different complications that may arise. Obviously, again, then based on the physiology and pathology, how we can go for this management issue. So this is very important, not only for the postgraduates, for all of us. Thank you very much. Let's start the program and we will go for the discussion.
Thank you, sir. Thank you so much, sir. Yes, Dr. Basundhara, you can share your screen and start.
Yes,
Yes,
sir. Introduce yourselves, children.
Good morning, respected teachers and seniors. Myself, Dr. Dipanshi Garg, Junior Resident, AIMS Rishikesh.
Myself, Dr. Vasundhara Yerkade, Junior Resident, AIMS Rishikesh.
Today, we are doing a case presentation on postmenopausal vasomotor symptoms. A patient, 55-year-old, para to life to postmenopausal since 3 years, homemaker by occupation, resident of Gumaniwala, Rishikesh, Uttarakhand, presented an OPD with complaint of sudden heat sensation over face, neck, and chest since 4 years, which interferes her work. Patient also complained of perineal itching for 10 months. Patient was apparently well 4 years back when she had irregular menses for a period of 1 year, followed by cessation of menses 3 years back. Patient had complained of sudden sensation of heat over face, neck, and chest since 4 years, followed by sweating associated with anxiety, aggravated by stress and hot weather, 5 to 6 episodes per day, 2 to 3 episodes per night, each of them lasting for 2 to 3 minutes, hampering her day-to-day activities. Patient complains of irritability and insomnia. Patient also complained of vaginal dryness and perineal itching. There was no complaint of intolerance to heat or cold or palpitation, discharge per vaginum or bleeding per vaginum, no complaint of increased frequency of micturition or burning micturition or involuntary leakage of urine while straining or coughing, no bowel symptoms, no history of any hormonal drug intake or topical application. She attained menarche at 12 years of age. Patient had menopause 3 years back. Her previous cycles were regular. 4 to 5 day flow every 28 to 30 days, changing 3 pads per day. There was no history of dysmenorrhea or passage of clouds. She had irregular menses for a period of 1 year, every 2 to 3 months during her perimenopausal period. She is married since 30 years, non-consanguineous marriage, para to live to all full-term vaginal deliveries at hospital. She's not ligated. Her husband died 2 years ago. No history of any contraceptive usage previously. There is no known case of hypertension or diabetes, thyroid disorder, or asthma. There was history of laparoscopic cholecystectomy 10 years back. No history of any gynecological, breast cancer, or any other cancer in the family. Her bowel and bladder habits were normal. No history of any addiction. She was taking mixed diet. Total calorie intake was 1600 kilocalorie per day and total protein intake was 50 grams per day. She belongs to upper middle class by modified Swami scale.
Can we go back to the first slide, please?
Yes, ma'am.
Yeah, not this. Yeah. So she is, according to you, she's postmenopausal since 3 years and she's a homemaker by occupation. Okay, next slide. Now I want you to describe, so what do you think she is suffering from?
Ma'am, she's suffering from postmenopausal vasomotor symptoms, hot flashes, and also genitourinary syndrome of menopause, which includes urinary, sexual, and sexual complaints.
What about hot flushes?
So now,
Night sweats.
can you describe a hot flush?
Ma'am, hot flash is a sudden feeling of heat sensation, mainly over upper body, face, neck, and chest, in which due to increase in core body temperature, followed by perspiration, anxiety, calmness, chills.
Okay, how long does the hot phase last?
Ma'am, 1 to 5 minutes.
Okay, and why does she suddenly start perspiring? What brings it out?
Ma'am, because her core body temperature, when it comes, it decreases, then it is followed by sweating.
Peripheral vasodilation.
Yes, ma'am.
Yes, that is the
cutaneous peripheral vasodilation.
Yes, that is the body's mechanism to deal with the increase in core body temperature to about, normally how much is it increased?
0.4 degrees Celsius.
According to studies, it is 0.4 degrees centigrade. So because the core body temperature increases, the body tries to dissipate the heat by causing peripheral vasodilation, and this causes sweating. Okay, and this sweating brings down the temperature and causes chills. So you have to describe this whole thing. Okay, now
In hot flush.
Right. Go to the, somebody is asking, I can't hear.
Madam, I'm Dr. Vijayalakshmi. This is called mean hot flush score, madam. According to that, how severe it is.
Yeah, she will. Dr. Vijayalakshmi is asking you, how do you grade hot flushes?
Ma'am, hot flushes are graded as mild, moderate, and severe.
Yes.
Mild hot flush, it is called when there is feeling of sudden warm, but there is no sweating and her activities are not affected. Moderate is when patient is complaining of hot flushes along with the presence of sweating, and the activities are affected to a less extent. Whereas severe defines that patient is complaining of hot flushes associated with sweating and strongly affecting her usual activities.
Okay.
See, sweating is there in all phases.
All phases.
Palpitations is not there. Okay. So
Yes, ma'am.
associated with palpitations also and interfering with her usual activities. So what stage do you think, what grade do you think this patient is having?
Severe.
Severe grade. Very good. Go to the next slide, please. Well, now, so she also complains of night sweats. You must mention that too when you're talking. Okay, because that gives a different complexion to the whole thing regarding treatment. When we come to management, we will discuss that. Next slide. Yeah.
Yes,
Doctor, one thing that, go back to the previous slide. Earlier, yeah. You see the first line you have written, patient was apparently well for 4 years back when she had irregular menses for a period of 1 year, followed by cessation of menses 3 years back. That means that you want to mean that she had some irregular menses for a period of 1 year, and thereafter she went into the phase of menopause.
Yes,
Is
sir.
it that you want to say?
Yes, sir.
Perimenopausal
Dr.
transition.
Vasundhara, yeah?
Yes, sir. Yes.
Right, you are. If it is so, is it the normal onset of menopause? Because the sequences of menstrual history, irregular menses for a period of 1 year, followed by cessation, is that what's the meaning? That what the question is, how is the onset of menopause at the end of this reproductive phase? How is the onset of menopause, menstrual cycle?
Sir, in perimenopausal phase,
Yeah.
first
Transition, you know, perimenopausal, there are different terminology. Transition phase, how that sequence of menstruation from that of in the phase of regular cycles to that of the menopause, that transition phase, how it
Sir,
how
in
it is.
reproductive years, she'll have her usual cycles. Then in late reproductive years, patients start having short cycles. Then as she enter in the phase of menopause transition, then patient first will have irregular cycles. Here, by irregular cycles, we mean that her cycle length will vary for more than 7 days. Then after that, she'll have a period where she'll have even a period of amenorrhea for more than 60 days during her late menopausal transition years. Then after that, she'll have there will be a time then she'll have a final period, final menstruation. Then after 1 year of final menstruation, we'll call her menopause.
That
Sarah
means
is asking irregular menses for last 1 year before
Yeah.
she got menopause. How frequently she got her periods
yes,
the
right.
last 1 year?
Yeah.
Sarah is asking
It's a 2 to 3 months cycle. She said 60 sometime in 2 months.
That's a good idea. Probably it is better to write it down so that we know that it is a sequence of normal transition that she is passing on. Good, carry on.
Okay, tell me now, in what different varieties does the vasomotor symptoms manifest itself? Like in this patient, it started after the final menstrual period or before the final menstrual period?
Ma'am, before.
the final menstruation.
Before the final menstrual, right?
Yes.
So the 1 year, that is -1. That is the, according to Strauss classification, she
Yes,
must have got it at -1 stage.
Yes, ma'am.
So that
What is the
common way.
significance?
So tell me the different ways it manifests itself.
Ma'am, it can manifest in the perimenopausal transition before menopause. It can manifest later. It can manifest first in the early phase, that is before menopause. It can present after menopause also, after few years of menopause in the early menopausal, postmenopausal phase, that is +1. It can also present in the late menopause, but +1B, ma'am. Usually later symptoms are genitourinary.
What is modified ankle sarya score?
There are 4 ways in which it can present. What is
Early appearance. Early appearance.
Early is before the menopause.
Final menstrual period, and then they'll disappear. Yes, ma'am.
Second thing is it presents with the after the final menstrual period.
Menstrual period.
And then it lasts for a shorter time. But again, the third thing is it starts early, but is very severe, like how you have it in your patient. And the fourth one is it starts early, but it goes on and on, not very severe.
long period.
Mild, it goes on for a long time. Now you tell me, if it starts early, does it go for a long time, the duration, or if it starts late? When is the duration long? According
Ma'am, if it starts early.
if it starts early, it remains for a longer time. Yeah, that's
Yes,
right.
ma'am.
That's perfectly right. Okay. Now,
What is modified Ankles-Sarya score, ma'am?
huh?
Madam, modified Ankles-Sarya score, there is one score. It gives a window of opportunity. If the perimenopausal transition only patient having that much symptoms, we can treat the patient according to the severity of symptoms. We can prevent in perimenopause also, in postmenopausal vasomotor symptoms.
What are the risk factors for hot flushes?
Ma'am, obesity, hypertension, alcohol intake, alcohol withdrawal.
You're
opioid
talking about the differential diagnosis. I'm asking you, what are the risk factors?
Ma'am, risk factors are obesity. If
Stop at obesity first. Do you think it is something which is natural that she should have more hot flushes, or do you think there is a paradox there?
There is a paradox. Because ma'am, if the patient is obese, then she must be having more estrogen from the peripheral conversion. But and if there is estrogen, then hot flashes should not be there. But what we see is in obese patient, we have more risk of hot flashes despite that. So it is a paradox.
Very good. What are the other risk factors?
Smoking.
Huh?
Smoking is the risk factor.
Yes, very good. Again, the third one.
Alcohol intake.
Huh?
Alcohol intake.
Okay. Okay. So what about socioeconomic status? Does it play a role?
Yes, ma'am. Low socioeconomic
status is associated.
Low socioeconomic status is what is written in books. What is your practical experience?
Ma'am, usually in our OPD, we experience that patients of high socioeconomical status, they come with this presenting complaint of hot flushes.
So it is possible, that's right. It is possible that low socioeconomic patients may have more hot flushes, but they do not come to us with their complaints. So that is the reason why we do not know whether they have it or not. But it's definitely the upper socioeconomic patients who Google and then who come and ask us for treatment. Okay.
Yes, ma'am.
Now, any other risk factors? Do you have any genetic predisposition to hot flushes?
Yes, ma'am. There is on chromosome 4, there are single nucleotide polymorphism. Locus is TACR. Then there is predisposition that in these patients, there is more chances of vasomotor symptoms.
Good, very good. Now, can you tell me what are the other conditions where you can see hot flushes and which can serve as a differential diagnosis, in the sense you have to rule out these conditions before you presume that it is only because of menopause?
Yes, ma'am. It includes hyperthyroidism.
See, your voice is a little echoing. So
hello, ma'am.
More clear about it. Can you?
Yes, ma'am. We'll try.
Yeah, please.
Is it fine now, ma'am?
Yeah, better. Yes, much better.
Ma'am, there can be same picture in cases of hyperthyroidism, alcohol intake or withdrawal, opioid intake or withdrawal, then some tumors like carcinoid syndrome, pheochromocytoma, some history of any drug intake like SSRI, anti-estrogens, then ma'am, smoking.
Antihypertensives.
Yes, ma'am. Yes, ma'am.
Yeah, very good. That's true. So now you are going to go to the next one. Next slide. Yeah, you have described all this. Next slide. Okay.
Good morning, everyone. Jyotika.
Hi,
Good morning, students.
Good morning, sir.
Just go to the
Good
previous
morning,
slide.
sir.
I wanted to. Good morning. Good morning. I just wanted to make one point clear from the slide. Just go back one slide.
Yes, sir.
And I just want to understand the PG is different. Understand the difference between this statement of intolerance, no complaint of intolerance to heat or cold palpitations. So no complaint of intolerance to heat. Is it different from hot flashes, or they are same? Why do you have to write it separately that no complaint of intolerance to heat? Do the PGs understand these differences? If you understand, what is the difference? Let
Sir,
us know.
intolerance to heat, here we refer that even matlab in hot temperature, she cannot bear hot temperature. But in case of hot flash, what will happen is she'll have sudden feeling of heat dissipation from the body. Then she will feel that this is the hot environment, and then she requires some cool place, or she wants her AC to be on. So that is the difference.
See, the other.
So, in other words, intolerance to heat, the heat control mechanism of the body is normal, but in cases of excessive heat, that fails. Okay, but in cases of hot flashes, even if the temperature is normal, she feels it from within because of the internal changes. So one is changes related to the environment, and another is changes within ourselves or within the patient's own body. So that is a basic difference. Thank you. Go ahead, please.
No, see, I wanted you to tell in this slide that you have ruled out, at least from symptom-wise, hypothyroidism, one thing. Then again, that you've ruled out genitourinary syndrome of menopause. She has itching, no doubt, but that itching can be because of high blood sugar also. We don't know. We cannot assume that it is because of GSM. And then this is important because when you're treating her, if she has other menopausal problems or if she has other comorbidities, then our treatment modality changes. So it's important that you give importance to these factors when you're taking the history.
So exclusion of all these medical points from the history itself, like Jyotika suggested, I think the hypothyroidism is a good point, hypertension is a good point. All these points need to be, and diabetes is a very good, very important point. All these things can be excluded as far as practicable, but from the history itself. Another thing I would like to point out here is that hypothyroidism is more prone to cause cold intolerance than intolerance. So that is one important differentiating point. So you must write all this, you must learn all this and put it in the paper so the examiner understands that you know all these things. That's a very important point, isn't it? So whenever you write something, then it is translated as knowledge and the examiner is satisfied. Okay.
Next slide. Yeah, there's nothing very typical here. Okay. Go to the next one again. Nothing very important here. See here, past history you've written, but you must say she's not a known case. Medical history. I think we shouldn't include hypertension, diabetes and all in past history. You must put it as a special separate section as medical history, not a known case of hypertension, diabetes or asthma. Okay, next. Yeah, nothing much here. See here, upper middle class, we just discussed it earlier. Go to the next slide. And again, go to the previous one. I mentioned here that you should not say total calorie intake is 1600 kilocalories per day. You cannot say, you must say approximately.
Yes,
You have to say approximately. Please remember that. Don't be categorical about it because it's never true. Next slide. Now we can do this.
Obesity. BMI.
On general examination, the patient is conscious, cooperative, and well-oriented to time, place, and person. Her BMI is calculated to be 28 kg per meter square. Her vitals are, her blood pressure is 26/88 millimeters of mercury in right arm sitting position. Her pulse rate is 90 beats per minute, regular good volume. Her respiratory rate is 16 per minute. There is no pallor, cyanosis, icterus, pedal edema, or lymphadenopathy present.
Okay.
On systemic,
Patient is obese, BMI 28.
Go back to the previous. From this slide, what did you infer? That she's an obese person according to the BMI cutoff. and she is
Yes,
not a hypertensive. Two
Yes,
important points, right?
Yes, ma'am.
Go to the next one.
On systemic examination, on respiratory examination, bilateral air entry is equal, chest is clear and there is no added sound heard. On cardiovascular examination, S1, S2 heard, no murmur present. On thyroid examination, there is no abnormality detected. On bilateral examination, bilateral breasts are soft and no palpable mass felt.
What is the most important take-home message from this slide?
Some thyroid.
Thyroid. You
Thyroid
cannot
and breast.
have a palpable thyroid for her to have hypothyroidism. Okay,
Yes.
please remember. The other important point is that she does not have clinical breast examination is normal.
Yes.
Okay, it's important where management is concerned. Next slide.
On per abdominal examination, on inspection, the umbilicus is inverted, central, all quadrants of abdomen moving equally with respiration, laparoscopic scar marks seen in right hypochondrium, all hernia sites appear intact. On palpation, abdomen is soft, non-tender, there is no mass palpable, no organomegaly present. On percussion, resonant note heard over the abdomen. On auscultation, vowel sounds are present and are normal.
Basically, you should present this slide as on abdominal examination, nothing abnormal, no abnormality was detected. Next slide. You shouldn't waste so much of time on some things which are not relevant at all. Next.
On pelvic examination, inspection, external genitalia appears normal. Atrophic changes in vulva present. There is no leukoplakia. On perspeculum examination, the cervix appears stenotic. Transformation zone receding into the endocervical canal. Cervix is flushed with vagina. Vagina appears pale pink and dry. Vaginal rugosities are absent. There is no discharge or growth noted. There is no dribbling of urine on coughing when examined in a semi-filled bladder. On pervaginal examination, the cervix is small, firm, not bleeding on touch. Uterus is small in size, mobile, anteverted, and the bilateral fornices are free and non-tender.
So what have you assumed from this pelvic examination?
Ma'am, I have assumed that there are atrophic changes of postmenopausal patient. They are present, ma'am. Also, there are also cervical changes in a postmenopausal female. And the cervix is also flushed with vagina.
Yeah.
All the changes.
Now, when you say external genitalia appears normal, when you've got all these changes which have happened in the vagina and the cervix and the uterus, do you think the external genitalia will be normal?
Ma'am,
you will find that the labia majora, the fat fold in the labia has come down, right?
Yes, ma'am.
So you should be very this thing about, you cannot just make a statement that everything appears normal and leave it at that. Okay. Yeah. Okay. The next one, ma'am.
Jyotika, I just want to make a point here. Yeah. See, you're very true when you say about the changes in the fat fold in the labia majora. But the students must understand that it takes some time. You know, the atrophic changes in the vagina and the uterus, they start much earlier. In other words, the internal genital organs, they start their changes much earlier. But comparatively, the external genitalia retain their, structure and, integrity for quite some time. So you need to be very specific about finding of these, because finding of those things in the external genitalia is sign of quite a late menopause. So that is why the YSM term is important, the year since menopause. And the longer the duration of menopause, the atrophic changes will proceed more in the external genitalia.
To add, Basundhara, we need to correlate to what we say in the history and that of the examination. Your history, if we go by your history that you presented, that she suffered from that of the perineal itching quite a long duration. And on your inspection, external genitalia appears normal, atrophic changes in the vulva and lung leukoplakia. Was there anything clinical reason that she suffered for the itching perineal area for a long period of duration? And number two, let us, these things you need to be careful. So what we say and what we go for this examination, there should be a correlation, not to exaggerate things so that you are in a different situation. Now then, For vaginal examination, cervix small, firm, not bleeding on touch, uterus small size, mobile, and bilateral fornices free, non-tender. That's a good examination finding, that's fine. And in our situation, I would be rather happy when you say in the history, had she had this post-mortem bleeding regular any smear history? Was there any smear record? But if it was not there, so I would put some line or my examination finding that I have taken this smear because it was not done. Though the cervix is small, firm bleeding, no bleeding, it is good that we should take a smear also. So have some correlation, not that of the nitty-gritty of the history and things that often Dr. Jyotika says that sum up things to the relevant, focus the issue of problem and then discussion starts. So these are the two things that keep in mind that in particular in our country, cervical cancer and smear has got importance on this history and that of this examination finding and that of the perineal itching, what you have mentioned, and clinical finding does not correlate anything. So these are the issues that we need to think of. Keep in mind all this.
At least if you do not get anything
Yeah.
worth mentioning in the external genitalia, I think when you mention about the perineal itching, I think you should mention important negative point that there is no itch marks or scratch marks or soreness in the vulva that you should mention. This is one important negative point. If you don't find anything.
Rather, Professor Mukherjee, I would believe that if it is not the relevant, don't bring that issue.
No, if she has a complaint, no, she has a complaint of vagina.
And yeah, that you see that if there is a complaint and then there must be something.
That is why here in this case, I think it will be better if you write no scratch marks or itch marks in the vulva or the posterior part.
That was very necessary, children. Next slide.
Coming to the summary of the case, Mrs. X, a 55 years old, para to live 2, postmenopausal female who came with complaints of severe hot flushes associated with irritability and insomnia since 4 years and vaginal dryness and itching since 10 months. On examination, atrophic changes in vulva, vagina, and cervix are noted.
So how are you going to investigate her now?
No, summary, Dr. Basundara, I would feel talk about this pelvic observation, pelvic findings. Vagina, cervix noted. On examination, atrophic changes in the vulva, atrophic changes in the vagina and the cervix noted. What about the pelvic findings, the uterus size? Are you not happy to go for this? This is the summary you have finished, or you are going to say something more? Your findings on that of the examination, internal organs examination, have to be mentioned. Okay. That uterus is bulky, uterus is small, that you said atrophic, and fornices are clear, no tenderness, no pathology. Practically, your examination and finding does not reveal any obvious clinical pathology.
I think summary of the case has to be written a bit more elaborately because
comprehensive coverage there need to be.
In the summary of the case, you should mention that Mrs. X, 55 years, P2L2, postmenopausal, belonging to an upper socioeconomic status, staying approximately 7 kilometers from this hospital, came to the OPD with the complaints of severe hot flushes, associated irritability, insomnia, and vaginal dryness, and itching for 10 months. You should start like this. And then if on the general examination, specific things, on special exam and local examinations, so and so. So I think it should be a bit more elaborate, adding 3-4 more lines. It's a summary of the case, isn't it? This is the way you present to the examiner.
Can you just tell it out like how Dr. Ashish said just now? Can you rephrase your summary?
Yes, ma'am.
Quickly.
Mrs. X, a 55 years old, belonging to upper middle class by a modified Kuppu-Swami scale.
No, you don't need to repeat that. Don't go there. Everywhere Kuppu-Swami, that scale is not valid that way. So don't go for repeating the same thing, harping the same thing time and again.
And you say Mrs. X, 55 years. Don't say anybody old. Don't call anybody old, any lady.
Yeah, that's an important issue.
Mrs. X, 55 years, comma. P2L2, okay. Postmenopausal for 4 years. Came to the OPD, or rather staying approximately 1 kilometers from the hospital. Belonging to a low socioeconomic status, or average socioeconomic status. Came to the hospital with the complaints of severe hot flushes associated with irritability and insomnia since last 4 years, and vaginal dryness and itching for 10 months. This is the way of presentation. That means you bring the patient to the hospital. Then you say, mention about the general examination, then the local examination. Finish 3 or 4 sentences.
Relevant positive findings. You see,
Yeah.
this is a summary. Time has to be saved. Attention of the examiner has to be drawn with the relevant information which is focused.
So you got it?
Yes, sir.
ma'am.
That is the
Yes.
way you have to present, okay? Okay,
Yes.
now to the next one.
Ma'am, the provisional diagnosis of this case is 55 years, para to light to, postmenopausal female with menopausal vasomotor and genitourinary symptoms.
The genitourinary symptoms is a big question mark there because she has
Yeah.
pruritus valvae. She doesn't have any. No doubt, pruritus valvae is a part of the genitourinary syndrome, but it's not the main thing. So you can just
And you see, if you
leave it at that.
genitourinary symptoms, you have clearly mentioned she has got no problem in terms of urinary problem.
She doesn't-
Incontinence, frequency, urgency, stress, urge, nothing you have mentioned. You have not mentioned anything about their sexual life, like any difficulty or dryness or difficulty, pain, discipline, nothing that. So these are the many areas that gaps are there. I mean, continuity of the presentation and that examination and that of the making the diagnosis is not appropriate and relevant.
One important negative point, I think, is the absence of prolapse also, isn't it? So I think a lady who has given birth to 2 children by spontaneous vaginal delivery, if you do not have any degree of genital prolapse, I think you can mention it as a negative important finding. So far as the urinary symptoms are concerned, yes, she doesn't have any urinary symptoms, but it's a provisional diagnosis. If you want to make a provisional diagnosis of genitourinary symptoms, thinking that the itching may be a forerunner of many other genitourinary complaints, then that will prompt her to do many investigations. Okay. So provisional diagnosis is provisional diagnosis. But I think you should have some justification in making a provisional diagnosis. Like whatever you have got, you should present. And then you differential diagnosis and do the final diagnosis.
How will you investigate her now?
Ma'am, after taking the history and examination, we will do some basic investigations like complete blood count, her liver function test, her lipid profile. We will do a sugar profile like fasting PP and fasting and postprandial blood sugar, HbA1c. We will do an ECG, ma'am, and most basic for gynecological is pap smear. We would like to do a mammography, ma'am, breast mammography. Then an ultrasound pelvis if there is any complaint of previous abnormal uterine bleeding or any complaint of postmenopausal bleeding. Then we will do an ultrasound pelvis.
I think
Dr. Vasundhara, the case has already been presented. There is no scope now to have some imagination and I will go for all investigations from A to Z.
Yes, that's
The
true.
examiner would be looking for a relevant approach as a consultant, postgraduate. For your patient, you design the investigations for your patient. And you see that if you go on all talking of all mammography, your clinic, she hasn't got any problem. Your examination didn't reveal any abnormality. Are you happy? Are we going to, her main problem is the hot flashes.
Yes.
Basically, she has got nothing.
Yes,
And clinical examination is quite almost normal. So, but then we need to some areas, we need to go for the organized investigations to rule out any other pathology. But unnecessary investigations probably we won't go for.
actually, sir is right. But you can say that you're talking about the ideal situation. Where, you know,
No, practical situation is the reality is our patient. Ideal, there is nothing ideal now.
Yes.
It is the patient that is the ideal.
Yes.
We are talking with the patient.
There is a point here that you see, first of all, we ourselves are divided in the opinion of importance of mammography. Okay, these days. Okay. Secondly, on one point, on one end, you say that the clinical examination breasts are normal. They have mentioned that. And I don't think that being menopausal, gives you the right to go for routine mammography in all patients, unless and until you own a mammography clinic yourself. Okay. So I think,
No,
I think
but Dr. Ashish,
No, probably no. There is no such rationality going for investigations.
pap smear is okay. The
See,
number
as a
needed to
postgraduate.
treat is in pap smear. Pap smear is much more important. That is routine, okay. But
I would
now-
have been happy when you presented the case that I have done this, I have taken this smear. This is a more sensible, appropriate approach for a postgraduate that scores you good marks.
see, I just want to make a point here.
Hmm.
That the recommendation, the postgraduates are supposed to know the recommendations.
Hmm.
What we do practically is a totally different issue. They should know the recommendations that after the age of 50 years, there should be one mammography at least every 2 years. But in our country, in our circumstances, we cannot do it and we don't do it. In fact, I know that more than 80% of the gynecologists themselves have not had a mammography done. But they should be told the recommendation so that they'll tell you, practically we don't do it, but ideally this is the situation. Yeah. Okay, now tell us how you're going to manage this patient. Supposing you've investigated her and you did not, clinically, you did not find hypertension. On investigations, you did not find diabetes. There's no hypothyroidism. There is no breast cancer. So now you have a 55-year-old woman with severe vasomotor symptoms. We will keep the perineal itching to one side for some time. How are you going to manage the vasomotor symptoms?
Ma'am, for vasomotor symptoms, we'll tell her all the ways we have available. First, we can tell her the lifestyle modification, about lifestyle modification, and then pharmacotherapy, which can be hormonal or non-hormonal.
Devanshi, what do you base your treatment on? What considerations will make you decide on what to give her?
We will see what are the symptoms of the patient, how severe are they, then what the patient wants, then how compliant is she, how compliant or socio-economically will she follow the advice that we will give her. We will tell her about menopausal hormonal therapy.
What are the comorbidities she has? Okay, whether she has any contraindications for MHT.
Yes, ma'am.
Are the things which guide you. Okay,
Yes.
what will you choose for her?
Ma'am, in this case, as she is suffering from severe hot flushes, which is affecting her day-to-day activities, so the choice of menopausal hormonal therapy will be best for this patient, ma'am.
1 minute. What else will guide your therapy? She is less than 10 years post-menopause. She is
Yes,
less
ma'am.
than 60 years. See, your answer should have all the points so that nobody will ask you questions. Clear?
Yes, ma'am.
Okay, so you have decided on MHT. Fine. Now, what MHT and how long? Tell us.
Ma'am, we can, since she is post-menopausal, so we can give her continued
Continuous
continuous combined hormonal therapy, which includes estrogen as well as progesterone. Since she is having the uterus, so we won't go for a single estrogen therapy. We'll go for estrogen plus progesterone therapy.
Perfect. Now, what are the choices? Estrogen and progesterone. Come on, louder.
There's some problem with audio.
Yours is
Vasundhara,
Yes, sir.
Yeah, Vasundhara, stop sharing screening also. That will be better for interaction.
Yeah.
No? Can you
Yes, sir.
stop the share screen? Yeah.
Yes, sir.
Vasundhara, with the last electricity bill.
Hello, sir. Is it fine now?
It's
Now
better.
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 With intact uterus, you want to give estrogen and progesterone, which dose?
Ma'am, we can give 17 beta estradiol, 1 mg per day, plus a combination of progesterones like dydrogesterone. If it is continuous, we will give 5 mg per day. If it is combined, we can give combination which includes 10 mg per day, ma'am.
1 minute. She is postmenopausal. What will be your choice?
Continuous combined, ma'am.
Then that's it. You should not say 5 milligrams or 10 milligrams. If you are taking the decision, you should know what you're giving.
Yeah.
Why you are choosing
Dissemination.
estradiol and micronized, not dydrogesterone over the previous conjugated equine estrogens and MPA. Tell us why.
Ma'am, because the 17 beta estradiol has less side effects, ma'am. There is it also
Better effects on lipid profile, favorable effects on lipid profile.
What are the side effects? Effects of conjugate estrogens. Keep on telling on lipid profile, on sugars, okay, on cardiovascular status, on V. 111. Don't make us ask you, just tell it out.
Combined equine estrogen, it increases triglycerides level. So we are concerned about it. So we are preferring 17 beta estradiol. Then on carbohydrate metabolism, they have insulin resistance.
Esterification, it bypasses first pass metabolism and
Yes.
it decreases the side effects when compared to other estrogens. So ethinyl estradiol is better, and how it is advantage over conjugated equine estrogen. That's what madam is asking.
Yes, ma'am.
She's asking the same, Dr. Vijayalakshmi is asking the same question. Continue.
Yes, ma'am.
About transdermal. Okay. So
Yes, ma'am.
it favors carbohydrate metabolism, ma'am, conjugated equine estrogen. Then it increases when only it increases breast mineral density. Breast density.
Decreases heart attacks when compared to estrogen. Ethinyl estradiol.
The audio quality is not good, I must say.
in,
Audio quality is not good.
no, it's not at all good. So when Dr.
Interruptions.
also cannot be heard properly. See, in early menopause, if you give it, it has a cardioprotective effect. But later in menopause, if you give it after 10 years, then it is counterproductive and it can cause strokes and cardiovascular accidents. Okay. See, you must be quick in your answers. Come on, continue. So,
Yes,
and then what is the difference between oral estrogens and transdermal? Because that is why they try to overcome the side effects with oral estrogen by giving transdermal. In what way does transdermal score over oral estrogen?
Ma'am, if we go for transdermal estrogens, then first pass metabolism is bypassed. So we have less chances of stroke, side effects, stroke, insulin resistance, less GI side effects like cholecystitis or gallbladder stones. Then it is favorable
Good for lipids.
lipids. Even on lipid profile, it has a good effect. Because oral estrogen, they increase triglyceride, but this transdermal has favorable effect.
There is decreased risk of venous thromboembolism also, ma'am, and stroke with the transdermal.
All the differences, very good. So now you're going to put your patient on MHT. Okay, she is compliant. She's going to come for follow-ups. It's very essential that she should be coming for follow-ups. Now tell me, how long will you give her MHT? How long can you give according to recommendations?
Ma'am, we will give her for 2 to 3 years, but according to the latest guideline as per the North American Menopausal Society, which came in 2022, it suggests that we can also give extended menopausal hormone therapy.
You're right about it, but it is not 2 to 3 years. It is 5 years.
5 years.
Okay, I've told you already, it is 5 years. So the minimum, when they say you should be given for a short time, they mean 5 years. Okay, so the extended hormonal profile is given to those people after 5 years. You continue it. You don't start it afresh. You continue it. If the patients have not recovered from their symptomatology, you take them into confidence, because it's important that the patient also knows that you're doing something which is not the done thing, because she's not recovered. So she has to keep coming for follow-ups. Is it clear?
Yes, ma'am.
Yeah.
I think 2 to 3 points about the MHT. I'm happy at the way that our students answered this question, because in exam, whenever you ask this question, the immediate answer by the students is, sir, estrogen. What do you do in the management? The immediate answer is estrogen. So they have approached this question well. I mean, the changes in the lifestyle pattern of the lady is very important. Along with that, please add the emotional support and the mental support from the partner, from the family. Economic support is very, very important. because most of the drugs are becoming more and more costlier.
Yes.
MHT has to be given, but your answer was quite okay. Everybody is preferring these days 17-beta estradiol. But along with all the points that you have mentioned, you must add that the conjugated equine estrogen and the MPA, the combination mostly studied. That is the important thing about, in postgraduate level, they're very well established drug because it has been studied very well. So that is also important. Of course, the theories are coming out in favor of 17-beta estradiol. These days, more and more studies are coming out. So I think you should say both, because in postgraduate level, you should say both. Thirdly, MHT, when you say about the recommendation of the American recommendation, you should also mention that the International Menopause Society, in their recommendation 2014, they have said the same thing. Initially, the concept was for 2 years. Now it is 5 years. It can be extended further. So I think these are the points that you should know about MHT. It's a very important issue.
And non-pharmacological therapy also, like regular exercise, yoga.
During the course of hormone therapy, patient need to be followed up on a regular basis. You see, this is very important, because though we are giving the combined therapy, estrogen and progesterone combined one, but nevertheless, patient needs to be followed up. There are risks, so patients should be warned. And regarding the evaluation of the patients, the diet, regarding the exercise, these are also supplementary for along with that of the MST.
Kunar. The children did answer well. Now the other question is, supposing she is not a compliant lady, okay? She's not a compliant person. She may not come for follow-up. And then you think of non-hormonal methods of combating hot flushes. How will you do it? Non-hormonal? What are the various groups of drugs which have been used and which have been found to be quite successful? Yes.
We have anti-epileptic drugs. Then we have antihypertensive.
First, the commonest. When you come to the less
antidepressant, SSRI and SNRI group of drugs.
Very good.
Then we have antihypertensive drugs like clonidine. And then we have GABA analogs.
Okay. Just about 2 minutes on the SSRIs. Which are the ones which have been, the FDA has approved for the only drug SSRI approved for hot flushes by FDA?
Paroxetine.
Very often. What is it?
Paroxetine.
How much?
7.5 mg per day.
Yeah. Now, what is the disadvantage of paroxetine, sertraline, fluoxetine?
Ma'am, if we give these drugs, if the patient is taking tamoxifen, then what these drugs do is they inhibit CYP2D6 enzyme, and because of that, there is decrease in bioavailability of tamoxifen.
Bioavailability of the active metabolite of
tamoxifen.
Okay, now tell us about SNRIs. Which are the ones which are very commonly used nowadays?
Venlafaxine.
Very good.
Venlafaxine. Desvenlafaxine.
Dose?
Ma'am, dose of venlafaxine is 37.5 to 75 mg per day.
Yes.
And that of
what is the disadvantage with venlafaxine and desvenlafaxine?
13 days.
Yes. You can have nausea, vomiting,
nausea. If stopped abruptly, it can cause nausea.
Must taper it slowly, not suddenly, because these side effects can be very problematic for the patient. Okay. What about which is the only antihypertensive used?
Clonidine. 0.5 milligram.
It is given as transdermal, 0.1, 0.2, 0.3. They don't give orally because side effects are quite bad. So what is the disadvantage with clonidine? Tell me.
Ma'am, rebound hypertension is the disadvantage, and also it decreases HDL.
No, the best thing about clonidine is that it is very effective against hot flushes.
Yes, ma'am.
Studies have shown that it is effective in almost 80% of cases. But because when you stop it, you have to taper the dose. Otherwise, you will have very severe rebound hypertension. Which is why it is not a very popular drug. Okay. Now, apart from these, do you think you can only give, supposing you want to give only progesterone for this patient? Is there any progesterone which has been tried and which is very successful, which all of us also can give?
Medroxyprogesterone acetate.
What progesterone acetate?
How?
400 to 500.
That's what I mentioned. When you mention the drug, you must tell the way it is given, the dose.
Yes, ma'am.
Wait for us to ask.
400 depot medroxyprogesterone 400 to 500 milligram. Yes, ma'am.
Excellent. Okay, what are the other methods which are available which we can give? They are called complementary and alternative therapy. They are called CAMs. Most of the patients use these. They don't come to us. Okay, only when none of these work for them, they come to us. So can you mention a few of the CAMs?
Ma'am, these can be acupressure, acupuncture, or cognitive behavior therapy, yoga, exercise. All these come under complementary alternative
Do you
therapies.
think has got a lot of benefit for the patient?
Ma'am, these acupuncture therapy and cognitive behavioral therapy.
No, not acupuncture or acupressure. Behavioral therapy has been found to be very effective, not only for this, but also for sleep disorders. If we didn't mention about anti-epileptics, I'm sorry, we just skipped over. Tell me about anti-epileptics.
Ma'am, we have gabapentin and pregabalin. These are the two anti-epileptic drugs we can give. They also help us about if the patient is having insomnia or night sweats, then they are the preferred drugs we give. Dose of gabapentin.
Like your patient is having night sweats, right? 2
Yes.
episodes you mentioned in the history. So gabapentin will be ideal for her. So
Yes,
can you tell me which part of the night you get the night sweats?
I'm in early phase.
During which part of the sleep?
In early phase.
REM sleep, ma'am. Initial 1 to 2 hours.
1 to 4
1 to
hours.
4 hours.
If she sleeps for 8 hours, but if she sleeps only for 3 hours, then the first 3 hours maybe. Okay. What happens in the second 3 hours or 4 hours? What type of sleep is there? All of us go through it.
In REM.
Rapid eye movement, REM.
Yes,
Yeah,
ma'am.
sleep prevents us from getting night sweats.
Night
So
sweats.
it's the first part of the sleep that she gets it. And gabapentin is specially indicated for night sweats.
Night sweats.
So supposing she does not have sweats throughout the day, she has only in the night, how will you give gabapentin?
Then when we
100
can give only a night dose, 100 mg.
1 hour before sleep. Okay, that should suffice. It will also, it's got a sedative effect also. So that also will help her. Okay. Now, what about phytoestrogens? You've heard about phytoestrogens?
Yes,
Most of
ma'am.
the time it is taken over the counter. What's
Yes.
your opinion on phytoestrogens?
Ma'am, phytoestrogens, they are the natural estrogens which we can get in fruits, vegetables. We have, they can be flavonoids and non-flavonoids. Flavonoids, they include diadazine and genistein. And in non-flavonoids, we have lignans
and comestin.
Regarding all the other therapies, but the yoga and the exercise are not the alternative, they are the adjunctive. Whenever the patient is on any mode of therapy like MST, she should continue that of the exercise and the yoga if they like. As I have told you, the diet also.
10 minutes again.
Yes.
I'll come. Yeah, yes, sir, doctor. That's very true. We should not forget about lifestyle modifications, whatever treatment we are giving, that comes first. It's only after we finish LSM do we come to the next pharmacotherapy. Okay. So now tell me one thing. Isoflavones, on which type of receptors do they act according to studies? We know that estrogen has alpha receptors and beta receptors. We are all scared of giving isoflavones because it can cause, we think it can cause breast cancer, it can cause endometrial cancer. They're the only two things which we are worried about when we give any drug which has not had many level 1 evidence studies. So can you tell me about the attraction of isoflavones to which type of receptors?
Ma'am, equal.
Okay, for that you should
Alpha and
know.
beta.
For that you should know the distribution of the receptors.
Alpha
Where do
and
you
beta
find alpha receptors? Where do you find beta receptors?
Ma'am, we find alpha receptors in uterus and breast. Then beta receptors we found at other places, blood vessels, vulva, vagina,
Most important, bone.
bones.
Bone, ma'am.
Yes,
Most
ma'am,
important,
bones.
bone. We shouldn't forget. And there are some tissues where you have both alpha and beta. Which are those? See, these
Ma'am,
are
vulva, vagina,
Yeah, tell us.
vulva, vagina,
Yes, urethra, bladder, trigone.
urethra, bladder,
Okay, these are
Yes.
some of the areas which are both alpha and beta.
beta.
So now tell me about isoflavones. Which
Ma'am, they act on beta receptors. They they do not act on alpha receptors. So that
exactly
is-
because of this, studies have shown that isoflavones are relatively safe. They can even be given in patients who have had breast cancer in the past.
Yes.
Because they're only sort of attached to beta receptors, bone, blood vessels everywhere. So they can give rise to better sort of symptoms. Though they are when you compare estrogens with isoflavones is a minuscule, very minuscule compared to the effect of estrogens. But then when you're giving it in large quantities like 60 mg per day or 120 mg per day, they do act. And there are some studies which show, I told you, not level 1 studies, which show that they do cause decrease in vasomotor symptoms in about 60 to 70%. I think we are almost coming to the end. What about the placebo effect? When you give only placebos, how do you think the patient will respond? To what extent?
Ma'am, 20
There are studies which show that even placebo can come to about 30 to 50%.
Yes.
Unless your medicine gives relief more than 50%, you can only call it as a placebo effect. Okay, so you need to be very sure. Now there are so many items in your kitchen, like fennel. Okay, you have fennel is there, then yam is there. All these are also very good source of isoflavones.
Red clover.
Red clover.
Black cohosh.
Yeah, you have black cohosh, red clover, St. John's wort. But the
Yes.
problem with all of these is that they have
Shatavari.
side effects. Okay,
Yes.
St. John's wort is very good for depression. Actually, when you compare it with antidepressants, it's as good as antidepressants. But the problem with the St. John's wort is it can have liver problems too. So you need to, most of them have liver problems. So you need to be careful when you're prescribing. Okay.
One more thing, madam. Conjugated equine estrogen along with the tissue selective estrogen complex, bezodoxifene.
Thank you, Vijayalakshmi. We forgot to mention that. Yes, we didn't mention two things. One is the tissue specific estrogen complex. What is it?
Bezodoxifene.
It is a combination of conjugated equine estrogen and bezodoxifene, ma'am.
Yes. What is the
So-
dose of each?
Ma'am, the dose of conjugated equine estrogen is 0.625 mg per day, and bezodoxifene
0.4. Here it is 0.45. Okay. And how much of bezodoxifene?
20 mg, ma'am.
Very good.
Bezodoxifene 20 mg.
What is the advantage of bezodoxifene? This tissue specific estrogen complex. What is the
Ma'am,
advantage?
we do not need to add any progesterone in this because bezodoxin itself has anti-estrogenic effect. So whatever estrogen we are giving, it will take care of it.
What about in breast cancer patients? Are we okay with it?
Yes,
Yes,
ma'am.
ma'am.
Not so okay, because there are some studies
Little bit.
that it can cause. See, the thing is that there are so many of these hormones which we give. We need to be careful with breast cancer. Now, one thing is tibolone. We didn't mention tibolone also. This bezodoxifene and conjugated equine estrogen combination is very effective also in patients who have had endometriosis and have undergone TAH plus BSO and who have menopausal flushes. In such patients, we can give tissue-specific estrogen complex without much of a problem. Okay. Now, can you tell us about tibolone? Does tibolone help in hot flushes? In
Yes,
vasomotor symptoms?
Yes, ma'am. It helps.
Advantage of tibolone and what is the dosage?
Ma'am, tibolone, it is a STAR, selective tissue estrogen activity receptor. Its advantage is that it has three metabolites. It forms three metabolites: estrogen, progesterone, and androgen. Due to the progesterone and androgenic component, ma'am, it affects, it elevates the mood. So it had extra effect on the mood, as well as it is useful in sexual discomfort problems also, ma'am. The dose of tibolone is 2.5 mg OD. Usual dose.
1.25 is good enough. Okay.
Yes, ma'am. Low
1.25
dose.
is same. Now, what is the problem with tibolone?
Stroke.
We do not have much of the cardiovascular risk assessment for the tibolone, and also there is risk of venous thromboembolism or stroke in this patient.
And thromboembolism, very good. The other one is that it does not initiate breast cancer. But if you're giving it in a patient who has breast cancer, it has a higher rate of recurrence.
Recurrence, yes, ma'am.
So you need to be careful. It's like, you know, you're like a seesaw. You go up, you go down like a balance, everything, and only then give these medicines. Clear?
Yes, ma'am.
What about the perineal itching? We didn't touch it only. What do you want to do with that?
Ma'am, for perineal itching, we can give local vaginal estrogens. They act locally and they are very good for the genital.
First of all, find out if she is using any of these feminine washes and all.
Yes, ma'am.
Irritants and any history of worm infestation also. Sometimes worm infestation also sometimes.
Yes, perfect. So we need to rule out all the other causes. Only after that, you come to a conclusion that it could be because, and then you said that her husband is not alive. He passed away 2 years back. So she won't be having any problems with intercourse.
Yes.
So if she has, she says she has dryness of the vagina, right?
Yes,
Now, if she is on systemic MHT, to a certain extent, that dryness of the vagina will be taken care of by the systemic MHT. But if she had some urinary problems, urge and all that, the systemic MHT will not sort of address properly. For that, you should only give local. But she doesn't have urge. She has only dryness of the vagina and she has a little bit of itching. So you can use a very low, because she has a uterus, you can give a low potency vaginal cream if the systemic MHT does not work, because you can combine the two. But if you are giving non-hormonal other methods, then you can use a local vaginal estrogen cream. You have with estriol, you have with estrione, you have it conjugated equine estrogens. There are so many preparations in the market. She can use it happily for how long? For how long? Safety.
Ma'am, 1 year.
1 year.
1 year.
Full one.
Very good. You can use it because safety profile is there only for 1 year. She can use it for 1 year. That's one thing. And do you need to do some endometrial surveillance when she's on local vaginal estrogens? Yes, no.
Ma'am, if we are using low dose, then
No.
not required.
Low dose only. Nothing like that. Okay. So no,
No.
no endometrial surveillance necessary. Right. Now the recent NAM guideline, the recommendations, they call the position statement. They also say, normally we don't give up to 60 years, right? If the patient is more than 60 years, we do not give MHT. We try to look at other sort of medications to help her out. But NAM says that if there is genitourinary syndrome of menopause, even if she is 80 years, you cannot withhold local estrogen creams for that lady. Okay? So that's the latest. So we should know what the latest is. Clear? Did we finish our presentation, their presentation, Dr. Ashish? Ashish, hey,
I just wanted to make a few comments before we close.
Yeah.
While going for pharmacotherapy, systemic or local,
yeah,
I think we need to take care of a few things. Number one, listen to the complaints of the patient very carefully. If the patient is predominantly presenting with the hot flashes, I think majority of the patients, 70-75% will present with hot flashes. I think the first pharmacological intervention after excluding all the contraindications should be estrogen. Nothing works like estrogen there. After the patient is satisfied with the progress of the improvement in the hot flashes, only they will we can go for, or after crossing of 5 years, whichever happens later, then we can think of others. The age barrier is just a theoretical barrier, but then other pharmacotherapy and other aspects of the drug therapy should be taken up only after the initial part. That means the hot flashes are reasonably cured by the, improved by the patient. So I think, and that way we can, and local estrogen therapy is always safe. It doesn't mandate the endometrial surveillance, as Dr. Jyotika said very correctly. But then we need to be careful about exclusion of other comorbidities or other conditions which will, as it is necessitated, the endometrial surveillance and endometrial sampling. And I think now we can close this case and then go for the second case, Dr. Ashok Kumar.
Yes, sir. It is time we should move on to the second. Thank you so much for all the students and the faculty and my teachers and all the participants for sparing your valuable time and giving the inputs. We had very fruitful discussion by Dr. Jyotika Desai and Dr. Ashish Mukhopadhyay and Dr. Hiralal sir also. Thank you very much. So, Dr. Hafiz,
Yes, sir.
Move on to the second case.
Correct. Yes, sir. So for the second case.
Thank you very much. Thank you, everyone.
Yes, sir. Konar sir and Jyotika madam would request to be there if you are available for the second case as well. So, Mr. Zignesh, I'd like to Sarita madam to unmute. Yeah, madam is there. So for the second, yeah, for the second case, the students from Alamin Medical College, Vijaypura. So they are guided by Dr. Vidya Thabi and Dr. Gururaj Deshpande, and students are Dr. Bipula and Dr. Shabnam. Are you there, both of you?
Officer, I just want to congratulate the Rishikesh students for doing a very good.
Yes,
Yeah,
madam. They have done a good job.
Thank you,
Student
ma'am. Thank you, sir.
Keep doing good. That's it's our wish, and I'm sure this will give you lots of positive thing for you as well as confidence for future.
No, Dr. Hafiz, just I want to remind everyone that this platforms gives the confidence also to the student, and it gives the student also a layout that what all is important while they study themselves.
True, sir. That is always I have been telling them off the screen. That is, this will give you a lot. This is a good platform to give you a confidence as well as to present you in any platform, because that is gives them the confidence.
Because
So,
what we are doing is we have students from different parts, examiner from different parts of the country. Because
True,
what
sir.
is happening is in the same institute, we are all familiar with all ourselves. So it becomes sometimes limited information and limited knowledge. By involving a galaxy of teachers from different part of the country, the spectrum is and the horizon widens. That is the main purpose of this program.
Yes, sir. I keep always telling them they remove their fear of aura of fear before there is presentation in this platform. What they used to go before the presentation, and I'm sure that gives them lots of confidence once they cross over up to this.
Yes.
Professor Ashok and Professor Hafiz,
Yes,
this is true. It's a wide exposure, as you have said, different examiners from the different parts of the country. But what we are more focusing, our habit, if you have this exposure to the international field, our Indian students, as an Indian student, we have got the habit of reading huge and lots of information, so that whenever opportunity comes, we will go with that. But most of the time, what I was at times focusing to be particularly specific to that particular case that you are dealing with.
Yes.
So don't forget that case that you are dealing, because in an other situation, because we are having international examination these days, even in India. So it will be more appropriate and relevant if you focus your discussion, keeping in mind the correlation, what you have said in the history, what you are going to present in the examination finding, there should be a correlation. And
Yes,
regarding the treatment part of issue, focus precisely initially with that of the particular problem that you are facing, that you are given with the case. And then you can go for the detail of discussion whenever the discussion comes. So
Yes,
this
sir.
orientation, rather than knowing everything and at the time of need, relevant information regarding the particular case management, we are lacking. That's a bit of gap that probably need to be overcome. That's the reason it's a good opportunity. and good discussion with all these national teachers and different teachers from the parts of the country. Thanks, great.
I
Thank you
totally
for having
agree
this
with, sir,
opportunity.
totally agree with you. And this is the purpose of our program also, is that this platform gives the opportunity to student. So we want to convey the message that they have to focus on a particular situation at a time. That is the important message. Dr. Hafiz, yes, please continue.
Yes,
Ashish and Hafiz, please, I have to go.
Thank you, madam.
well, ma'am. Thank you so much, ma'am, for your time as well as for your presence.
Thank
So
you.
for
Thank you,
the
Jyotika. Jyotika,
Yes.
thank you.
Thank you, sir. Thank you so much.
Great. You
For
have
this-
taken the lead.
For the next case, the postmenopausal bleeding. So the students from Al-Amin Medical College, Dr. Vipula and Dr. Sabnam. So please share your screen and start presenting. As I'd request the faculties, Dr. Sarita Valero madam and Dr. Vijay Lakshmi, as well as Dr. Ashish sir and Dr. Hirala Kumari sir is already there. So please take over, and the student, yeah, please make it slideshow.
Yes.
Good afternoon, esteemed faculty. I'm Dr. Vipula S. from Al-Amin Medical College.
Please go ahead.
Yes, go ahead.
Yes.
Vipula.
Sir, Shabnam will be presenting the history part, sir.
Okay. Very Shabnam.
Yes.
Doesn't matter. You go ahead. I think he has some connection issues.
Okay, sir. Okay, sir.
Shabnam is there? No. I see Shabnam is. Yeah, Shabnam. I can see you. Please go ahead. No, we cannot hear you, Shabnam.
Shabnam has got some audio issues, I think.
It's audio issue.
Hmm.
So Vipula, you go. In the meantime, Shabnam, you can see now. We can see you are unmuted, but we don't. That's the what I was giving the trial for you.
Yes, I'll go ahead with the case, sir. This is our patient was Mrs. Vasundhara Kumari, aged 53 years. She was from Vijayapura, Karnataka, and she studied up till 12th standard and homemaker by occupation. And she belongs to middle socioeconomic status. And the date of admission to our hospital was on 15th of March, 2023. She came with the chief complaints of bleeding per vagina on and off since 6 months, sir. History of present illness. Patient was apparently well 6 months back, after which she noticed bleeding per vagina, which was initially spotting, where she used one pad per day, which lasted for 2 to 3 days. Later, patient noticed gradual increase in the quantity and duration of bleeding in the successive months, which was acyclical, where she had to use 4 to 5 pads per day for 5 to 6 days. There is no history of passage of clots, no history of postcoital bleeding. It is not associated with pain in the abdomen, offensive discharge per vagina or mass per vagina. No history of mass per abdomen, no history of similar complaints in the past, no history of fatigue, palpitation and breathlessness, no history of trauma or foreign body insertion in the vagina, no history of loss of appetite or loss of weight. There is no history of bleeding tendencies anywhere else in the body. There is no history of pain or fever, no history of altered bowel and bladder functions, no history of chronic drug intake other than the antihypertensive she is on, sir. No history of cancer screening in the past, and no history of hot flushes. Menstrual history, her age of menarche was 12 years. Previous cycles were regular. She used to get cycles every 28 to 30 days, and the flow lasted for 3 to 4 days, where she used to change 2 to 3 pads per day. It was not associated with any passage of clots or dysmenorrhea. She attained menopause at 51 years. That is, it was 2 years back she attained menopause. From 49 years of age, she had irregular cycles, which was prolonged cycles. Like she had cycles for every 2 to 3 months, where the flow of bleeding used to reduce. Like it was starting, it was 3 to 4 days and 2 to 3 days. Gradually, it reduced and stopped at 51 years. And there is no history of menopause hormone therapy. Obstetric history, age at marriage was 20 years. She conceived spontaneously after 1 year of marriage, and she is a para 2 living 2. Both were full-term normal deliveries. Antenatal, intrapartum, and postpartum period were uneventful. And last childbirth was 30 years back, and she underwent laparoscopic sterilization 28 years back. There's no history of combined oral contraceptive usage. Past history, she's a known case of hypertension since 6 years, and she's on regular medication for the same. She's not a known case of diabetes, thyroid disorders, bronchial asthma. There's no history of previous surgeries, and no history of any chronic drug intake other than the antihypertensives. Family history, no history of breast, colorectal, ovarian, or endometrial cancers in the past in the family. No history of bleeding disorders. Personal history, she consumes a vegetarian diet and her appetite is normal. Sleep pattern is normal. Bowel and bladder movements are regular. She's a non-smoker and a non-alcoholic. I will continue.
I think before you go into examination,
Yes, sir.
just suggest 2 or 3 things in the history part. One is that if you can go back to the slides now.
Yes, sir.
And we are actually divided in opinion about how much we should expose about the name of the patient. But while presentation, you may conveniently camouflage the name of the patient as VK instead of writing Vasundhara Kumari.
Okay.
That's one suggestion.
Yes.
Okay. Secondly, the residence Vijayapura is really not very well understood by the examiner. How far distant it is from your treating hospital is important. I think the amount of travel that she has to undertake before taking any medical treatment is important. This is important in obstetric cases, but for gynecological cases also, this is very important that how frequently she can come for follow-up, etc., etc. So I think that is more important information than writing the name of the city or the town or the village, etc., etc.
Yes.
Thirdly, I think education of the husband is also important. Education, you have written just 12th standard, and that is why in the socioeconomic status, we write 4 points. One is the type of residence, whether she lives in a rural or an urban or a semi-urban area. Then there comes the education. Education means education of the husband, education of the wife. Thirdly, the environmental sanitation and potable water, and the monthly family income. So all these 4 points should come in the separate heading called the socio-economic history, which is very relevant in our country. That is my suggestion. And the 4th point is, you have written, next slide, please, next 2 slides. Diet, I think it's not a personal thing. Diet, I think it should be written in a separate heading. Nutritional and dietetic history, separate history hona chahiye. Because in a personal history, you just write about the diet. That's, I think it's not enough.
Bipula, one more point to add from the history.
Yes, sir.
You see, time allotted for presentation and case discussion is limited.
Yes.
So as much time is used fruitfully for that of the quality of presentation and the discussion, that is more important. Rather than what I observed, there are 17 points talking about the no. It's not needed. No, in postgraduate examination, you say the relevant information, that's positive information.
When they present the case, this is not the way they present in the exam. This is just noting the documents. When they come to the summary, that is actually the presentation of the case. Because all these things, we are having the advantage because we are having the online platform. In exam,
that's a good idea, but here you are presenting a case. If examiner wants to listen to the case, talk about the case, you see, it depends on the examination scenario.
Presentation is different. Presentation will be different. This is noting down all the points. These are important. Otherwise, the examiners won't be able to know the facts.
No, to be relevant, postgraduate examination, my opinion, of course, it may differ. 17 no points is unnecessary waste of time. You talk in a precise way what is relevant, pertaining to the case discussion, management, and discussion. So this is one. But 17 no points listening to this with the time is not purposeful. So carry on then.
Shabnam, you are audible now?
Shabnam.
Shabnam, your device has some problem. You log out.
I think we can't hear her. There's some audio issue. I think the other
can-
girl can take over, no? Vipula, why?
Yeah,
Yes,
yeah,
sir.
yes.
Yes, ma'am. I'll
Just
continue,
let's
ma'am.
take it
Yes,
because
ma'am,
they
I'll
are
continue,
from
ma'am.
different device.
Hi, Sarita.
Shabnam, you can log in from a different device or from a mobile if you want to participate. And
I'll tell
Vipula,
her
you,
to. Yes,
yeah,
sir.
you
I'll
go ahead.
continue, ma'am. Yes, ma'am.
You-
So continuing with the general physical examination, a middle-aged woman, moderately built and well-nourished, and she is well-oriented to time, place, and person. Pallor, mild pallor is present. There is no icterus or pedal edema, no lymphadenopathy. Pulse rate is 90 beats per minute and regular, and blood pressure was 140 by 90 millimeters of mercury in the right arm sitting position, and temperature is normal. Weight is 68 kgs and height is 155 centimeters. So our BMI was calculated to be 28.3 kg per meter square. And on examination, thyroid, no abnormality was detected. Bilateral breast examination, no evidence of lump, and nipples is normal. Spine, no abnormality detected. Systemic
Dr.
examination.
Vipula, just one question. Why is BMI relevant and important in this case?
Ma'am, obesity is a risk factor for endometrial hyperplasia and as well as endometrial carcinoma, ma'am. So I have mentioned obesity, BMI.
Good, yeah.
Systemic examination, CVS and RS system, no abnormality was detected. On per abdomen examination, there was no abnormality detected. Inspection, abdomen is flat and umbilicus is central in position and inverted. All quadrants of abdomen were moving equally with respiration. No engorged veins, scars or sinuses. Hernial orifices appear to be intact. On palpation, inspectory findings were confirmed. No local rise of temperature, tenderness. No evidence of any mass per abdomen and no evidence of hepatosplenomegaly. On percussion, tympanic note was heard, and there is no evidence of free fluid per abdomen. On auscultation, normal bowel sounds was heard, and there is no evidence of bruit. Local examination, external genitalia appears to be normal. There is no local lesions seen. On per speculum examination, vagina appears to be healthy. Cervix is posterior in position. External os appears normal, and there is no foul-smelling discharge, or there is no bleed per os noted, and pap smear was taken. On bimanual examination, cervix is facing downwards and forwards, firm in consistency, mobile, no cervical motion tenderness. Uterus is anteverted, bulky. It is mobile and non-tender. Bilateral forenessus is free and non-tender. On rectovaginal examination, rectal mucosa is free and parametrium is free. Summary, a 53-year-old para-2 living to postmenopausal lady since 2 years. She came with complaints of postmenopausal bleeding on and off episodes since 6 months, which is acyclical in nature, heavy flow. That is, the flow lasted for 5 to 6 days with the usage of 4 to 5 pads per day. She is a known case of hypertension since 6 years and on regular medication, and BP was on general examination. Mild pallor is present and BP is 140 by 90 millimeters of mercury in sitting position, and BMI is 28 kg per meter square. And on local examination, uterus appears to be bulky and bilateral forenessus is free. So provisional diagnosis is endometrial hyperplasia. A provisional diagnosis, 53-year-old para-2 living to postmenopausal lady with postmenopausal bleeding, query endometrial hyperplasia or endometrial carcinoma.
You do not put query in provisional diagnosis. Provisional diagnosis itself is a query,
Yes,
and which is needs to be corrected and confirmed by investigations and then the final diagnosis.
Yes.
In the previous slide, you can safely delete the provisional diagnosis part because the last line is there.
We have put, yes.
Summary writing is very, very important. What the question Hiralalda raised, this is the point they present to the examiner. This is the slide they present to the examiner. They do not present no anemia, no cyanosis, no jaundice, no clapping, no edema. They do not present that. What I insist in the postgraduates is that this summary development is very, very important, extremely important. Whatever the findings that you have mentioned in the previous slide, you keep it written in the note sheet, which will be handed over to the examiner. She will go on seeing that. But while you say to the examiner, when the examiner asks you, what is your case, you should stick to this slide that is summary. Because the examiner's patience will be there for only 2 to 3 minutes, not more than that. Okay. So I think you need to build up this summary very, very well. Very well. Including all important findings, all important positive findings, excluding all important negative findings, etc., etc. Sarita, your input, please.
Yes, I think that is correct. My first question is to how do you define postmenopausal bleeding?
Shabnam, are you audible now, ma'am?
Yes, sir. Yes, sir.
Yeah.
Good afternoon. Yes, sir.
Ma'am is back. Yeah.
Ma'am, postmenopausal is defined as cessation of menstrual cycles for more than 1 year, ma'am.
That is the definition of menopause. So postmenopausal bleeding is any bleeding which is occurring
After 1 year, ma'am.
after 1 year of the final menstrual period. Okay. Yes, doctor, you can go ahead.
Postgraduates can also say that any amount of bleeding, either in duration or in amount, after the menopause is established. I think you can, that is a safe way of answering instead of saying 1 year or so, because that there may be some this side or that side in that definition. Any time-bound definition is bound to be, mixed up with, other things. So I think postgraduates can say, for undergraduate, that definition is okay. But postgraduates can reasonably say that after the menopause is established. Yes, Hiralalda.
Professor Mukherjee, one line of discussion for all of us, including the candidate. Provisional diagnosis, query endometrial hyperplasia, oblique endometrial carcinoma. As you have already mentioned that provisional diagnosis, query doesn't come, it is a provisional diagnosis. Endometrial hyperplasia is a histopathologic diagnosis.
Correct.
We are making the case clinical only. Endometrial carcinoma is a histological diagnosis by microscope by the pathologist. So it is not relevant that in provisional diagnosis you mentioned that it is a postmenopausal bleeding. There are many areas of postmenopausal bleeding. It could be endometrial, and then it will be confirmed later on with the investigation. That's the purpose the case has come. So probably we won't go by that terminology.
No, but Hiralalda, I slightly differ from you. Postmenopausal bleeding is an event. Whenever you talk about provisional diagnosis, what the student is thinking in this case, what is the cause of that bleeding, right? So if they can write endometrial carcinoma, I'm pretty happy. And although it is a histological term, endometrial hyperplasia is so very common, it comes in textbooks and other things. If they can mention and they can establish it, I think I'll accept this. No problem. There are individual variations in us.
It is a histological diagnosis, pathological diagnosis.
That is true, but
so hyperplasia or carcinoma, probably I will reserve it.
I think we can accept both options. They can also say postmenopausal bleeding for further investigations. Or they can say this way. Both options, I think we should give correct.
Correct. Sarita,
let's go to the further investigation.
The point here is that, see, the whole purpose of the case history taking is that the student should have a clinical diagnosis. That's why provisional diagnosis is also called a clinical diagnosis. What is this? It may be a case of atrophic vaginitis. So there are umpteen possibilities. So I think any one of them the student should mention and then try to negate or substantiate the diagnosis.
Postmenopausal bleeding, awaiting investigations.
So I think let's go further and let's ask them that now what would be your next course of action?
Yes,
ma'am, I would like to confirm my diagnosis first, ma'am. So she has come with the postmenopausal, she's come with postmenopausal bleeding. So first I would like to do transvaginal sonography, ma'am, for her.
What do you expect and what are the findings? What are you looking for?
In the transvaginal sonography, I would like to first look for the endometrial thickness, ma'am. And then for any localized endometrial lesion, like any polyp is there, or whether the regularity of the endometrium I would like to look at. And the endomyometrial junction I would like to look at, ma'am. And then next I would like to look at the adnexa, whether bilateral adnexa is normal or whether it is whether any abnormality is detected. And then whether there is any presence of
endometrial thickness, but you didn't tell us how much you expect.
Yes, ma'am. In a postmenopausal lady, I would expect it to be less than 4 mm, ma'am. Anything greater
Suppose
than...
she's on hormone therapy. Suppose she's a breast cancer survivor and she's on tamoxifen.
Yes, ma'am. That is a risk factor for endometrial carcinoma, ma'am.
What happens to the endometrial thickness then?
Increases.
Yes, Shabnam?
Endometrial thickness increases.
Right. So you would say that you want a 4 mm endometrial thickness in a patient who's not on hormone therapy. Right?
Yes,
whereas the figures will be different. Yes, Dr. Konar, you want to ask something?
No, that's fine. That's okay.
Okay, so I think she's talked about the sonography. Now you do, let's say that what were the sonography findings in this patient? Do you have them?
Yes, ma'am. The endometrial thickness was 10 mm, ma'am. And there was no any localized lesion as such, ma'am. And that much adnexa was clear, ma'am. Adnexa, no pathology was.
So what would you like to do next?
In this patient, because the endometrial thickness is 10 mm, so I would think of in the lines of endometrial hyperplasia or endometrial carcinoma as such. And I would like to first go for biopsy, ma'am, endometrial biopsy. If the setup is there, then the gold standard is hysteroscopy and biopsy. If I don't have a setup of hysteroscopy, then I would like to go for a pipple biopsy, ma'am.
Why you prefer to combine that of the hysteroscopy and that of the endometrial biopsy?
Yes, sir. Because first of all, the visualization of the uterus and the uterine cavity will be there. Endometrium can be visualized in hysteroscopy. So it will be a visual biopsy we can take instead of a blind biopsy. And then any local lesions also we can see under hysteroscopy. And then endometrial cavity can be visualized clearly, and endocervical junction and cervix can be visualized with hysteroscopy as such. And then if there is any polyp, we can combine it with operative hysteroscopy as well, and we can remove the pathology then and there.
In places where you have the facility of a hysteroscope, I think it's good to combine hysteroscopy and the endometrial sampling. It is always better, because your answer should be that in case of any small insignificant finding in the endometrium, we can spot that and we can direct our biopsy at that particular area.
Targeted biopsy.
In absence of targeted, this is more targeted biopsy. In absence of any particular specific lesion, you can take biopsy from any point. So it doesn't really matter. So that at that point, it is equivalent to taking a blind biopsy. But then that doesn't justify that the blind biopsy will be taken in all cases, particularly where the facilities exist. I think hysteroscopy guided biopsy is a better option than this should be your answer. Sir, we have the facility for hysteroscope, so we'll utilize that. Say like that.
I think it is the gold standard, no? As we say, hysteroscopy, endometrial biopsy is the gold standard. But having said that, are there any advantages and disadvantages of PIPL? Can you tell?
Yeah, they should say that. But before that, I just wanted to mention on a writer that the people who do not have the hysteroscopy facility, I think you should be honest enough. Sir, we do not have the facility of a hysteroscope, so I have to go for this. You can say like that, because you are not responsible for your setup. In a setup where from you are appearing at the MS examination, if you do not have the facility of hysteroscopy, don't get inhibited. So whatever you are practicing in your setup, you should mention that in the exam. Examiner always likes his honesty. You can always ask theoretically, what is the advantages of hysteroscopic biopsy over the conventional biopsy, etc., etc. But don't get inhibited by the fact that simple lack of hysteroscope will prevent us from the management of this patient. Okay.
But understanding should be there regarding that of the
We should know in theory.
So can you tell us what are the advantages and disadvantages of the PIPL?
Yes, ma'am.
Why is it not such a popular thing?
Advantages
are that it is procedure, ma'am. It can be done without any anesthesia, and the cervical dilatation is not needed as the diameter is very less, that is 3.2 mm. But the disadvantage is that it is expensive, ma'am.
No, it is not.
It's not expensive compared to hysteroscopy, not at all.
It is a simple catheter. It doesn't cost too much.
What is the main disadvantage of the PIPL?
We can't see, ma'am. If we take a biopsy from a place where it might be normal endometrium, the place that we take biopsy from.
So one thing is that false negative you may get. Second thing is it may not be possible in almost 25% of cases. It's not possible to negotiate the cervix. And the tissue which you obtain may be inadequate. So there are a lot of problems with that, which is why the popularity is not so good.
What about the other option? Are there anybody using this Shaman's curate in the OPD anymore? The OPD curate is.
Shaman's cannula, no?
No, Shaman's curate is a different instrument. It has got a small curating tip at the end of a uterine sound. Is anybody using this instrument? No.
Not commonly, probably they have not seen also.
Fine.
So what was the report when you did this patient?
Ma'am, the report was hyperplasia with atypia, ma'am.
Okay, so what would you like to, now can you tell us the types of hyperplasia? What is the classification of hyperplasia?
It is the adenomatous hyperplasia. Is it please?
WHO 2014 has classified endometrial hyperplasia as without atypia or with ATP.
There's something like simple and complex hyperplasia.
It's 1999, old WHO class.
Yeah.
Yeah, so there is simple hyperplasia with atypia, and there is complex hyperplasia with and without atypia, isn't it? And why is it classified like this? Is there any logic in this?
Risk of carcinoma increases as it goes with atypia with complexity.
So in your patient with complex hyperplasia and atypia, what is the cumulative risk of cancer?
29%.
Yeah, almost in the next 3-5 years. So how would you guide this patient?
She's a postmenopausal woman, ma'am. That too, she has hyperplasia with atypia. So I would like to give her the option of, I would like to proceed with total abdominal hysterectomy with bilateral salpingo-oophorectomy, ma'am. And would like to do a concurrent, she is with atypia, so there is no need for surgical staging in this patient, ma'am.
Okay, what are the risk factors for endometrial cancer?
Ma'am, prolonged or unopposed estrogen exposure, obesity, medical disorders like diabetes, hypertension.
What risk factors this patient had that to have this atypical endometrial hyperplasia? This patient that you were talking of, what risk factors she had?
She was obese class 1, ma'am, sir.
Have you done any investigations before going for that of this histoscopy and endometrial biopsy?
So I think she said that they have done hysteroscopy, endometrial biopsy, and the histopathy.
Did you look for any other factors during that prior to that histoscopy and endometrial biopsy? She is obese. She is a risk factor. Any other? Otherwise, what are the other risk factors for this endometrial hyperplasia and endometrial carcinoma? She is a high risk case. Have you looked into their glycemic status? Have you?
No.
This patient, your patient?
Not my, sir. She is euglycemic, sir.
Oh. All right. Good.
Okay, I think you mentioned diabetes, you mentioned obesity. Any other risk factors for hypertension? You said any other?
Age.
Age, yes. Anything else?
60 years. And then parity, nulliparity.
Yes. Anything else?
PCOS, or any other cause of chronic oligoanovulation.
Absolutely. Anything else? Some tablets she could be taking?
Yes, ma'am. Whether she was on tamoxifen or estrogen only hormone replacement therapy.
Absolutely, hormone replacement therapy or tamoxifen. Also early menarche and late menopause. Early menarche and late, these are all risk factors for endometrial. Now, suppose I tell you that you've done the histopath and the histopath has come endometrial adenocarcinoma. How would you proceed?
The biopsy report, and then endometrial adenocarcinoma, then the type, whether it is endometrioid type, I think they would have mentioned in the reports. So
it's well differentiated adenocarcinoma.
Then I would like to go for laparotomy and surgical staging, ma'am.
Do you like to go for these days any facilities that we can have this idea regarding the once the report comes, the adenocarcinoma of the endometrium? Any other investigations?
Any imaging that you would
MRI is
what for?
Why?
MRI can detect myometrial invasion, ma'am.
Sure.
And if there is any parametric invasion, and if there is cervical extension.
Absolutely. We have got the opportunity to go.
What is the importance of myometrial invasion?
Ma'am, if myometrial invasion is more than 50%, then the risk of lymph node involvement is more, ma'am.
Can you tell us the staging of endometrial carcinoma?
Yes, ma'am. Stage 1 is the carcinoma is confined to the corpus, uterine corpus. The stage 1 is further divided as a stage 1A and 1B, wherein 1A will be having less than 50% of myometrial invasion and 1B with more than 50% of myometrial invasion. Stage 2 is involvement of the cervical stroma. Stage 3 is local and or regional spread of the tumor. It is further divided as A, B, and C, wherein A is involvement of the uterine serosa and or adnexa. 3B is involvement of the parametrium, and 3C is involvement of the lymph nodes, which is further divided as C1 and C2. C1 is involvement of the pelvic lymph nodes and C2 is the paraaortic lymph nodes. Stage 4 is distant metastasis, which is further divided as A and B. A is involvement of bowel and or bladder. Stage 4B is distant metastasis, including the inguinal lymph nodes.
That's good. And can you tell me now, how does your surgery change? So in this patient, what did you do for the patient? What was the surgical staging?
Ma'am, our patient was just with endometrial hyperplasia.
Your patient was only endometrial hyperplasia. So suppose it is endometrial adenocarcinoma and it is stage 1.
Yes, ma'am.
Stage 1A. What is the treatment?
Ma'am, type 1 hysterectomy or extrafacial hysterectomy is to be done, ma'am.
What do you mean by the extrafacial hysterectomy?
Sir, wherein the uterus and the cervix with the surrounding paracervical fascia is removed, sir.
Sure, sure.
Yeah, Dr. Ashish, you want to ask something?
Yeah, no, it's okay. We'll go ahead.
What will happen if there is extension of the endometrial carcinoma to the endocervix? Subnum? You know, sometimes.
Sir, extension into the cervical stroma epithelium is now taken as stage 1 only, sir.
Yeah.
But invasion to the cervical stroma is taken as stage 2, sir, according to the newer class.
What are the other causes of postmenopausal bleeding?
The most common cause of
genital causes and extra genital causes, ma'am. In genital causes, we have atrophic endometritis, which is the most common cause. Then endometrial hyperplasia, endometrial carcinoma, endometrial polyp. The cervical causes like cervical polyp or cancer cervix, decubitus ulcers, and atrophic vaginitis. Whereas extragenital causes, we have hematuria or hemorrhoids.
Now, did this patient, had she ever had a pap smear? Did you mention it in your history?
She had not taken prior, ma'am. We have taken, and the pap smear was not.
Yeah. So I think that's an important thing that we should mention in the history. What is the history of pap smear taken earlier? So now I'm going to ask you that suppose you examine this patient and you found a lesion on the cervix. How would you have proceeded? She has come to you with postmenopausal bleeding. She's never had a pap smear. You examine the cervix and you find a lesion on the cervix, a cauliflower-like growth on the cervix. How would you proceed?
I would like to take a cervical punch biopsy, ma'am, from the edge of the lesion, ma'am.
Okay. And suppose it is reported as cervical squamous cell carcinoma. Then what would you do?
Cervical carcinoma, the staging we would like to do, ma'am. Which stage she is, the treatment depends on that. So
is it a surgical staging or a clinical staging?
It's a clinical staging.
Can you tell me what is the staging of CA cervix?
Ma'am, stage 1 is stage 1. The cancer is confined only to the cervix, which is further divided as 1A and 1B. 1 is microscopic diagnosis, and 1B is obvious growth of the tumor. 1A is further divided as 1A1 and 1A2, with microscopic depth of elevation being less than 3 mm and 3 to 5 mm. And stage 1B, which is macroscopic appearance of the CA cervix, which is further divided as 1B1 and 1B2. B1 is less than 4 centimeters and B2 is more than 4 centimeters. Stage 2 is involvement of the parametrium. Stage 2B is involvement of the parametrium. Stage
Stage 2 is involving the vagina, but not extending to the lower 1/3 of vagina or beyond to the pelvic wall. Stage,
which is further divided as again as B2A1 and 2A2, ma'am. That is less than 4 centimeters and more than 4 centimeters. But stage 2B is involvement of parametrium, ma'am. And stage 3 is further divided as 3A and 3B. 3A is involvement of the lower 1/3 of the vagina, whereas 3B is involvement of the pelvic wall with the with or without hydronephrosis.
Involvement of parametrium up to lateral pelvic wall.
Yes, ma'am.
Yes.
And
Or
stage 4
hydronephrosis.
is distant metastasis, ma'am. A is involvement of bowel or bladder, and 4B is distant metastasis.
Okay, one more comment I had in your history. Did you mention whether this patient was on blood thinners?
she was not taking any other medication other than
So I think you should specifically ask for blood thinners because there are many patients who want blood thinners.
Yes.
One thing to add, Shabnam, that regarding the staging of carcinoma cervix, it is clinical, but it has been the latest staging 2013 that has been modified. That imaging help could be included, say for example the CT or the MRI. But if we consider the imaging studies for the staging, you know that clinical staging is a bit difficult and erroneous sometimes. So assessment of the parametrium, lateral pelvic wall, that makes it difficult clinically. But if we get the help of the MRI or the CT, then we have to mention that we have used that of these imaging studies, and then the other studies, IVU, everything we have to mention, because you know comparison of data, the survival outcome of patients with carcinoma cervix or carcinoma endometrium even today, that depends on the situation of the spread of the disease, stage of the disease. Clinically, we may be understaging the disease or overstaging the disease. That's the reason if we have used the help of the imaging studies, we should mention so that comparative assessment of this long-term survival outcome of the patient all over the world, your study comes into that group that imaging was used. And what type of imaging you have used? You have used the MRI. So that category of patients is differently assessed in terms of survival outcome. So this is important. Keep in mind, this has been classified again. Thank you.
Yes.
Carry on.
Yes.
Yeah. So suppose my question is there was atrophic vaginitis. You said it's a cause of postmenopausal bleeding. How would you treat?
Atrophic vaginitis only, ma'am, then I would like to give her local estrogen cream, ma'am, because she's postmenopausal. That is it helps in reduction of the bleeding because of atrophic vaginitis. Also, if there is any other causes of, I mean, if it is associated with atrophic endometritis or not, I would like to rule it out now.
How will you rule out atrophic endometritis? Is it possible?
Means it, if the endometrial thickness is less only, then we will further go
so
for
if
biopsy.
you see an atrophic endometrium on hysteroscopy,
yes.
and that may be the reason. And how will you give local estrogen? Can you tell me what preparation is available? What is the dose? How will you recommend? Any idea what preparations are available?
I think they have discussed extensively.
Creams are available, ma'am, and estradiol creams are available.
Creams are available, or cream? They have discussed it. So it is available, and it is as an ointment. No, it has to be used with an applicator, and usually we tell them to apply daily for the first 2 weeks, then alternate days, and then twice a week for maintenance. Yeah, it is available in 2-3 different companies. Avalon is available.
Yeah. Primarine is also there.
Is also available.
Yeah.
Okay. Yeah, Dr. Konar, you want to add?
So what other non-genital cause could be that of the, you were talking of the postmenopausal bleeding?
Sir, hematuria or hemorrhoids, sir.
How that confuses the diagnosis and how can you rule it out? Any idea that he must? Yeah?
I think very often patients do confuse it, and especially the hematuria. So we have to ask the history very carefully. Is it bleeding while passing urine test? And they
Urine
say
microscopy.
UTI, urinary tract infection, is very the common. So that is also a thing. Okay,
But
Dr.
even then, in a way of exclusion, we have to look for the genital organs also, that the smear and the general assessment of the patient to rule out any genital organ pathology. We need to rule it out.
Yes.
Yeah, Sarita, I think we have discussed extensively in the last case about the vaginal hormone therapy, local hormone therapy, etc. So I'd like to skip that. But one point the students must know about the diagnosis of atrophic endometrium and how do they diagnose that. They have said about the hysteroscopic appearance, okay. But suppose in centers where there is no hysteroscope, how will you diagnose? One point they have said about the TVS thickness.
Yes.
What is the upper limit of endometrium thickness, which is suggestive of normalcy?
4 mm in a postmenopausal lady, sir.
Yeah. No, remember the endometrial thickness is only useful in postmenopausal women. The endometrial thickness in the reproductive age group is not at all beneficial, not at all useful for any diagnosis. So you remember only one cutoff, that is 4 mm, and that too in the postmenopausal women. Okay, that is important. Second point is once upon a time we used to recommend endometrial curettage for the diagnosis of atrophic. We no longer recommend that because that causes more injury, invasion in the myometrium and bleeding. Okay, these 2 points you must remember.
Yes.
So anything else you want to ask, Sarita?
No, I think we are, I think Dr. Hiralal, if there are no further questions, we can actually close the discussion. Dr. Hiralal, would you like to ask anything?
Well, all the areas has been covered, I believe. So
anything to you ask on the endometrial, you have asked about endometrial cancer, but about cervical cancer, any other malignancy in the genital tract, or you think that they should be dedicated to another webinar of the oncology webinar?
Well, they can attend, yeah, that's fine. But we have covered that of these
endometrial carcinoma cervix also.
Detail of it.
Cervix also we have covered cervix, we have covered.
Okay, thank you guys. So in that case, I think I have the pleasant task of offering the vote of thanks. Sarita, thank you so much.
Thank you. Pleasure.
First of all, I must convey my thanks to Dr. Hrishikesh Pai, our president, with some motto in mind, and that is why he has progressed this far in the PG teaching programs. I also offer my thanks to Dr. Madhuri Patel, then Dr. Lakshmi Srikandesh, who unfortunately she couldn't be present over here today, but she's always a constant source of inspiration. Dr. Ashok Kumar had to leave for some important job, so he has delegated this job to me. I'm thankful to him. Then Dr. Hafizur Rahman, a constant partner of myself on the right side. He is always encouraging the students. He's always accumulating data about the students and organizing these events. I'm thankful to him, Hafizur. Then I thank the faculty and the coordinators from AIMS Rishikesh. They have done wonderfully well. Your students did exceptionally good. And the examiners, Dr. Jyotika Desai, Dr. Vasundhara, Dr. Hiralal Konar, Dr. Sarita Valera. You did an extremely wonderful job. Students appearing today, Dr. Dipanshi, Dr. Vasundhara, Dr. Vipula, and Dr. Shabnam. All of you have done wonderfully well, and all of you have passed with flying colors. So now we are closing for today. Now you should remember that the main purpose of this PG teaching session is that inspiring you. PG teaching is like an open ring. Knowledge is also like an open ring. It is endless. But our idea is to stimulate your learning and thereby increasing your interest so that you can proceed further in the path of life. Thank you very much for everything, and
Sir,
all of you.
Sir,
Yes.
with your permission, one word.
Yes,
In fact, I was caught unaware. Sarita, in the morning hours, I could see that the ICOG CME is there. So I thought, Cholo, let's go and sit over there and listen to this. Then I was caught by Professor Ashok Kumar and Professor Hafiz. That Professor Kunar is also in there because Professor Mukherjee was absent that time. So it is an incident that I was caught. Thank you very much. Anyway, I have participated, I have learned, I have helped as much as possible. It's a great way of learning and teaching all the time. You know, as a teacher also, we are learning, Sarita. We all agree. We are all learning and we are developing every day. We make this study. Thank you all. Wish you all the best. Keep on doing and keep in touch with ICOG faculties whenever you need it. It's a
So I
great
invite
exposure.
you over the next meeting next month, 14th May 2023 at 11:30 a.m. Over to Hafizur for closure. Hafizur, you are there, no?
Yes, sir.
Hafizur is always there.
Thank you. Thank you so much, Ashish sir. You have been always. In fact, we have been the strength of source. That is, we are sticking with the programs and it's going good. And very soon we'll be at least completing 2 years. And Konar sir, it is always pleasure to have you there. That is, we're happy and we're lucky to have you
My
today.
addiction and passion probably that pushed me to sit over here this morning, and I was caught.
Yes.
Great.
Thank you,
I have
Sarita,
enjoyed.
madam.
Yeah, I have enjoyed.
Yeah, ma'am. Sarita, ma'am. Dr. Zatika, Dr. Vijay Lakshmi, and of course, Ashok sir is there, and our President FOGSI, Dr. Rishikesh Pai, and ICOG chairperson, Lakshmi Srikante, madam. So all the students, that is, you have done really fantastic, and I have always kept telling you when you were that is, we are about to present or preparing for a presentation. That is, this is a very wonderful opportunity for all of you, and I'm sure this will give you lots of confidence as well as lots of opportunity for in future also. So thank you so much, everyone. Thank you all the faculties and all the students, again, all the institutions and all the coordinators, especially from AIMS, Dr. Anupama Bahadur, and from the Alamin Medical College, Dr. Vidya Thabi madam and Gururaj Deshpande. So thank you so much.
Thank you, sir. Thank you.
Thank you. Bye-bye.